Okay, I think we can get started, and I'm very pleased this morning to welcome everyone to this international webinar. My name is Carissa Patricelli. I'm a physician in family medicine and addiction medicine. I'm coming to you from BC Women's Hospital, and I'm the president of the Federation of Medical Women of Canada. We are very pleased to bring this webinar on behalf of the Federation of Medical Women, hosted by the Vancouver branch in partnership with the Myalgic, Encephalitis and Fibromyalgia Society of BC, who've brought together a wonderful panel of speakers. And I'll start by acknowledging the traditional, ancestral, and unceded territories of our Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations, on which we are so honored to live, work, and play. And with that, I'd like to introduce our moderator, Dr. Teresa Clark, who is a long-term member of the Federation of Medical Women of Canada and past president of the Vancouver branch. So thank you very much for moderating, Teresa, and take it away. I think you're just on mute, Teresa. So if you want to unmute.
Yes. Thank you.
Wonderful.
Thank you. I'm honored to represent the Federation of Medical Women of Canada Vancouver branch to moderate this webinar on myalgic encephalomyelitis, also known as ME, chronic fatigue syndrome, or ME/CFS. As a physician of the Complex Chronic Diseases Program, I finally worked out all that terminology. I'm very aware of the need to improve awareness and education in the medical community on ME, as there are significant issues regarding delay in diagnosis, lack of access to healthcare services, treatment, long-term disability, and unmet needs for patients disabled with ME, as well as lack of research funding in proportion to the prevalence of ME in the population. Before we begin today's event, I'd like to state that all medical and scientific information presented today is considered to be accurate as of the date of this event, September 22nd, 2021. Please consult your medical professional for the latest developments. Now, please join us as we welcome Dr. Nina Muirhead and Dr. Lucinda Bateman, international experts on ME, to learn more about this complex chronic illness. Together, they'll walk us through diagnosis, management, and current biomedical research findings. A panel discussion featuring Dr. Louise Nacul from BC Women's Hospital Complex Chronic Diseases Program will follow. Please use the chat box to enter your questions as we go along. Your questions will be discussed during the Q&A after the panel. This webinar is 1 hour and 15 minutes, and the Q&A will be the last 15 minutes. If your question is for a specific member of the panel, please note the name of the panelist before your question. Now, our first speaker is Dr. Nina Muirhead. Dr. Muirhead is a UK surgeon, medical educator, researcher, Oxford graduate, and individual living with ME. She became severely unwell with ME following glandular fever in 2016, spent much of 2017 bedbound and housebound, and required a wheelchair until early 2019. She is now able to work part-time as a dermatologist and spends her free time trying to improve education about ME for health and social care professionals. Over to you, Dr. Muirhead.
Well, thank you for all the lovely introduction and this opportunity to speak. So I'm going to share my screen, hopefully get this up fairly quickly for you. Everyone can mute who's listening in, that would be great. So we'll go straight in with my own personal story. So I'm a UK doctor and I love medical education. And for once, I have something to teach about. In September 2016, I had infectious mononucleosis, so Epstein-Barr virus, glandular fever. And to begin with, I wasn't particularly unwell, a little bit like the long COVID stories that are coming through of a fairly mild viral infection. I actually carried on working for several months, but was finding that in the days after doing exercise, I was becoming increasingly exhausted, getting sore throats and flu-like symptoms. And I finally got a diagnosis of ME/CFS nearly a whole year later. I saw 13 different doctors and ended up very severely incapacitated. I'm fortunate to be working part-time now, but that has just been luck because my illness has become slightly less severe. So what is ME? It's a devastating, chronic, complex, multi-system disease. Myalgic encephalomyelitis is made up of muscle pain, myalgic, and inflammation of the brain and spinal cord, encephalomyelitis. There is some issues around the naming of the disease. It is best referred to as myalgic encephalomyelitis, or ME. However, internationally, patients may have already been labeled or diagnosed with chronic fatigue syndrome, which can then be conflated or confused with just other chronic fatigue. So it's very important to get the terminology right and to make sure the patient is happy with what you're labeling them. There are approximately 600,000 sufferers in Canada, and there probably will be more following COVID. In some of the literature, the female to male preponderance is 4:1 and others estimate 3:1. But nevertheless, it is obvious that like other autoimmune disease like multiple sclerosis, there is a female predominance. It affects both children and adults, and nearly 80% are thought to be triggered by a viral infection. 40% have a first-degree relative with an autoimmune condition, and there are many other overlapping syndromes. And it affects all ethnic and cultural backgrounds and may be more common in ethnic minorities, and this is often underestimated. Prognosis is unknown, and in some of the literature, it is estimated that only 5% recover. Many do maintain a lifestyle that they can cope with and much less severe, but they never fully go back to their pre-illness state. So it's always nice to have photos, makes it more engaging. This is me, this is my life before I got ill, very active, mum of 2 lovely children, doctor, enjoyed cycling, skiing, running. And then suddenly in 2016, I started to develop sore throats, tachycardia, flu-like symptoms, difficulty walking, high temperatures, and I was functioning at a fraction of my pre-illness capacity, and this continued for many months. I was getting relapsing and remitting viral symptoms, so I felt like I was coming down with the flu, and then I would feel better for a few days, think I was coming out of it, take on a bit more, then go straight back in. So it was very fluctuating in the early months. I also had headaches, facial pain, vomiting, muscle twitching, joint pains, difficulty thinking straight, difficulty multitasking. I had a new onset of food hypersensitivities and skin rashes. I was also getting a lot of cardiovascular and gastrointestinal symptoms, so shortness of breath, chest pains, atypical chest pains around my back, cramps, muscle twitching, diarrhea, intolerance to light and noise, heat and cold, tinnitus, dry eyes at night, dizziness, stumbling, and needing to sit or lie down, sometimes in the middle of cooking a meal, sometimes in the middle of having a conversation, and even in public places and in the shower. So this was really invading my quality of life and causing a significant harm to my general health, and it meant that I was unable to work.
Enjoy the lecture. Apparently it's in person.
I've got some background noise again. Put on mute. So the really interesting thing is that I'm not a hypochondriac. I'm a very stoic person, and all of these multi-system symptoms are very typical of a patient with ME/CFS. And I think it's something that can be really picked out of the medical history when you ask. So my own learning point from my personal experience is this is a serious disease with fluctuating multi-system symptoms, which can cause a major impact on function and quality of life. It is not well understood or diagnosed by the medical profession. Before I got ill, I didn't know about this illness. And I also thought it may have been to do with deconditioning and depression, and that certainly wasn't the case. I was not depressed, and because some days I could walk up the stairs and other days I couldn't even lift my head off the pillow, I could tell that this was not to do with deconditioning either. It was very fluctuating. Severity and relapses are not caused by thoughts and feelings. So often a patient will think, what have I done to cause this? And it's the same with our inflammatory conditions and rashes, and patients think, have I changed my lifestyle, my washing powder? But actually often it's an integral disease process going on that they could have done nothing to change. It's a shame that ME is difficult to diagnose, because having experienced it myself, it's very easy. There is a pattern and it's always very similar, and I'm going to walk you through it. But the stumbling block for a lot of physicians has been there's been no reliable biomarker. There are no consistent clinical signs on examination, although there are many signs to find. This is a heterogeneous group of patients. Some will have got ill very acutely, whereas others will have had a much slower, more relapsing, remitting disease profile. Different triggers and different body systems are affected to different amounts, different people and different timescales. And there are many different and conflicting theories in the literature. For the purpose of today's talk, I'm just going to walk you through the Canadian consensus criteria and the IOM, which we'll come to on the next slide. I am aware of the time, so I keep this brief. Going around from the top, post-exertional malaise or post-exertional fatigue. This is when you do something and in the hours, days or weeks afterwards, you start to feel sicker and less able to function normally. Sleep dysfunction, cognitive or neurological symptoms, orthostatic intolerance, irritable bowel and heart problems, body temperature changes, immune system symptoms, fatigue severe enough to prevent normal activities, and pain, which can be muscle, joint pain or headaches. And I actually found that deep bone pain and skin feeling like it was burning were all part of my symptomatology. This is a very recent data collection from surveying long COVID patients. And as you can see, most of those diagnostic criteria are coming up repeatedly in those who having persisting multi-system symptoms after long COVID. And I think it's something that's really important, and Cindy may come on to discuss a little bit more about this next. So the IOM criteria, which are much easier in that sort of intense clinical encounter, if you could just go through a quick list of 4 things and try and rule this diagnosis in or out, it's really useful. So this is fatigue impairing function more than 50%, the post-exertional malaise that I spoke about, and this can be even something trivial. Having a conversation for an hour can be enough to put someone out of action or reduce their functioning for a couple of days. Having a shower, cleaning their teeth. So it can be a small amount of cognitive or physical effort that's triggered post-exertional malaise. Unrefreshing sleep, which can be abnormal dreams, difficulty getting to sleep, difficulty waking up, feeling exhausted and more tired when you wake up than when you went to bed. And orthostatic intolerance or cognitive impairment. And these are both important to ask about. And orthostatic intolerance can be measured. So I'm going to whiz through these helpful questions about what to ask to pick up post-exertional malaise. One is, what fraction of your pre-illness capacity are you functioning at? And do split up mental and physical, because that's actually quite helpful to document. How many hours a day can you function? productively or do useful things. Some people can say just half an hour, I get things done, and then that's it, I'm wiped out for the day. How many hours a day are your feet on the floor? And Cindy mentions that as well. What happens when you engage in normal things? If you go out with friends, is that it for a month? Do you avoid or change certain activities because of what happens after you do them? What can or can't you manage on a good or bad day? And how long does it take? For me, at times, it took up to 4 days for the post-exertional malaise to kick in, because I would be running on adrenaline for the first day or two after I'd overdone it. And how long does it take to recover or get back to baseline? A lot of patients just say, I'm sick, I know I'm ill, I just couldn't function as normal, my neck would get stiff, I got headaches, I'm just not well, I feel like I'm getting the flu. So quite a lot of the patients' comments are really, really helpful for trying to trigger you to ask those four or five main questions. For patients, it's really hard to get their story across, so you've got to really help them. And if they're really struggling, maybe get them to come back again with the help of an adult. Routine tests obviously need to be done to rule out other differentials, and the NASA lean test is for orthostatic intolerance, and something that Cindy will go through. If there are focal neurological signs, then it's very important to do an MRI scan to rule out other pathology.
1 minute, Dr. Muirhead.
Thank you, that's lovely. So I think it's really important to be proactive about making a diagnosis, and then keep looking for other things afterwards, and keep looking for the other comorbidities, and document all of them, not just the main one. Treat the symptoms. So I'm going to move on to the symptom treatment slide, because this is really important and a very good crib sheet. There are plenty of treatments for patients. Medical support for their symptoms can really improve quality of life. Physical support, wheelchairs, walking aids, pressure garments, fluid loading can be incredibly helpful. A lot of patients have mast cell and antihistamines, H1, H2 are incredibly useful. And for orthostatic intolerance, there are a range of cardiology drugs now available. And for pain, cut down until you're not experiencing symptoms. Exercise does make patients worse, and fitness can deteriorate on the day after exercise when you do repeat cardiopulmonary testing. And that is worse as the patient is more severe, and that's statistically significant. So a more severe patient cannot exercise as much, and they have a greater impact physiologically from exercising. So exercise is not helpful for these patients. They also have a reduced cerebral blood flow, and many have orthostatic intolerance. So I'm just going to leave it on this last slide in the last few seconds. We're hopefully soon going to be publishing some work on family impact of quality of life, because this disease has a major impact on quality of life. And we did a study on 1,418 patients and their family members, and showed a statistically significant greater impact, not only on their patients, but their family members as well. And this was significant with a p-value of 0.00, less than 0.001. So look out for that publication soon in the literature. And interestingly, it was greater than long COVID and cancer. So please recognize the symptoms, make a diagnosis, treat the symptoms, don't advise exercise, acknowledge how much they must be suffering and how much their families are suffering. It's a very interesting field. I'm really looking forward to the other two presentations, so I will finish there. Thank you all so much. Thank you for the organisers.
Thank you, Dr. Muirhead. Our next speaker is Dr. Lucinda Bateman. Dr. Bateman is the founder and medical director of Bateman Horne Center in Utah and is recognized worldwide as an expert in the diagnosis and treatment of ME/CFS. She completed her bachelor and master degrees at Brigham Young University and a doctor of medicine at Johns Hopkins in Maryland. Dr. Bateman completed an internal medicine residency at the University of Utah and became certified by the American Board of Internal Medicine in 1991. Since 2000, she has focused on the diagnosis, management, and treatment of ME, CFS, fibromyalgia, and related comorbidities. Over to you, Dr. Bateman.
Thank you very much. It's a pleasure to be here. Let me get my screen up here. That was just wonderful. Thank you so much. I enjoyed your presentation, Dr. Muirhead. It was excellent. What I'd like to do is look at this illness from a little different approach, ways that we can help clinicians wrap their mind around doing this. Oh, there we go. So just a little background, Bateman Horne Center is where I work. It's a nonprofit clinic and research center where we also focus on education. And we've just gone through a beautiful presentation describing ME/CFS. And the reason we attach the name chronic fatigue syndrome in the US is really just to help bridge the awareness between that old term and the new term that we consider a preferable term, and also because of the extensive literature in the research calling it chronic fatigue syndrome. And again, I won't spend too much time going over the Institute of Medicine or the National Academy of Medicine criteria. These are evidence-based criteria from the literature of many, many studies looking at ME/CFS, especially in people who have been diagnosed by ME/CFS specialists. And these core criteria are not the only symptoms of illness, right? But what they are is the criteria that are common to everyone with ME/CFS, despite the heterogeneity. So these core criteria: impairment of function, post-exertional malaise, very disrupted and refreshing sleep, and then at least one of the following: cognitive impairment, orthostatic intolerance. And the most important thing to make these criteria effective is to assess frequency and severity. These symptoms must all be present. They must be moderate to severe and present a majority of the time. And then remember that these other symptoms are very common: chronic pain, immune and inflammatory manifestation, infection manifestations, and what may be neuroendocrine manifestations. And this is a very simple approach I use to teach clinicians about how to address this illness. Number one is to identify and treat all other identifiable medical conditions, whether they're comorbid or underlying. And then the number one treatment is to help people learn how to modify their activity. And this is physical and cognitive activity, to pace their activity, reduce the severity and duration of post-exertional malaise. In my philosophy, you should have a goal of never inducing post-exertional malaise when you have this illness, and function within your envelope. Inducing post-exertional malaise is like illness relapse. So it sets people back, and I think it leads to additional comorbid conditions and a lower level of function down the road. And then addressing the major symptomatic aspects of illness. This is something we know how to do as clinicians. We just need permission to do it. And that is addressing sleep and helping the sleep become as restorative as possible. It will never be normal. This is centrally dysregulated sleep. And then to pay attention to pain, especially when pain is a stressor. This illness is subject to relapse under all kinds of environmental stressors: cognitive, physical, emotional stress. And when pain is a stressor, pain can also unravel this illness. So pain should be addressed. All orthostatic intolerance syndromes, and there's an excellent literature. We just have to look and assess to see the extent of orthostatic intolerance and try to understand the roots. And then remember that this is a devastating illness. One of this has reminded me in long COVID, because we've been seeing a large number of long COVID patients, and they're just in an emotional disaster, because this horrible illness, it's taken away everything they've had. They don't, they're in the early stages of illness. When I see patients with ME/CFS who've had their illness for years, they've moved into a place of acceptance, and mental health issues are much, much less of an issue. So you really have to take every case at its own face, so that this extent of the duration of illness and the stages of grief as people move through acceptance for this horrible, life-changing chronic illness. And remember that attempts to gain fitness are only as can be done within the energy envelope and compatible with their illness, never inducing post-exertional malaise, which is why pacing is the most important aspect of this illness. So there are many comorbid conditions of interest. And, we can call these different things. They can be overlapping, they can be symptoms of illness. And I've listed these to give you an idea of these places that you can get a hold of illness and take an approach to treating it and getting some diagnostic information. And I've listed them in a way in order of how familiar we are with these in medicine. So the first 5 up there, I think most of us can wrap our minds around as clinicians, even if you don't know about ME/CFS. I want to focus on the 2 red ones, which are orthostatic intolerance syndromes and the inflammatory response that is often attributed to mast cell activation in this disease, because I think these are very important comorbidities, but often missed by clinicians. And so I want to draw your attention to it. And then the ones on the bottom are they're present, a little more problematic, maybe a little more difficult to treat, or a little bit less, we're a little less certain about how to address them. So I just want to give you a very simple tool I use in discussing function with patients is for them to report their hours of upright activity. That's the term we've given it. And that is defined as their time with feet on the floor. So you have to ask the question clearly so people understand you're talking about time with feet on the floor. So sitting in place with your feet on the floor is also upright activity. Your body, the majority of your body is in an upright position. And from a lot of experience in the clinic, asking hundreds of patients about their hours of upright activity, I can tell you that normal healthy people have 14 to 17 hours of upright activity. In other words, when I roll out of bed in the morning, my feet are on the floor pretty much until I roll back into bed at night. Those with chronic illness, it may be 10 or 12, but it's a stunningly low number for people with ME/CFS. And I used to say 1 to 8, and then I got called on it by patients who are bedridden and actually can never have their feet on the floor, or have their feet on the floor less than a total hour in a 24-hour period. So this hours of upright activity immediately sorts out a group of people who have something very different than other causes of chronic fatigue. And I want to introduce you to a very simple test that everyone can do in the office. And it's called the 10-minute NASA lean test. And I put a very old, that's the reference of our test down below. But this really did come from early research in the NASA space program before they had a lot of high technology. It's just an orthostatic test, but it's standardized, objective, and it can be done in the office. The important thing that we neglect in medicine is you must set the baseline lying down at rest. So the first portion of the exam, the patients need to be lying in a quiet place in supine rest for 10 to 15 minutes to let their vital signs equilibrate with quiet supine rest. Then you stand the patient up at a nearby spot with their shoulders against the wall for balance. And try to get them to be in a very relaxed position. We just use a pulse ox for the pulse on one hand and a blood pressure cuff on the other arm. And we usually have 2 people doing this test, one to obtain the vital signs and one to record and also to observe the patient, because if the patient becomes near syncopal, we really need to abort the test before they fall down. So then you obtain a heart rate and blood pressure every 1 to 2 minutes for 10 minutes. It's very important to do this test for more than 5 minutes. And routinely, I was trained throughout my career and in the first decade of my practice to do this test. Most of the time we started from a seating position to standing, and we did it for 3 minutes. And I can tell you, I missed orthostatic intolerance in the first decade of my career as an internist. So I want to give you a couple of cases, and I'm going to use long COVID cases just because it's very relevant and very interesting right now. This is a 45-year-old male teacher who came in to our center who had COVID 7 months ago. He has fatigue, impaired function, post-exertional malaise, and we asked specifically in a questionnaire about the IOM criteria, the National Academy of Medicine criteria, and frequency and severity. So you can see it reflected here. He says that he ranks them as very severe and present 75 to 100% of the time. And then we ask about good day, bad day. So on good days, which are only 2 or 3 a month, he can manage 8 hours of upright activity, meaning, and then he gives us an example. He can walk around, lightly clean his house, but he cannot exercise or work. But on bad days, which are by far the majority of the month, 26 to 28 days per month, he can manage only 2 hours of upright activity. He can only sit on the couch, make simple food, can't stand for long, walk outside. This has been going on 7 months since he had acute COVID. And he gets post-exertional malaise after even low physical exertion, and it can be triggered by poor sleep. We ask for triggers. His sleep is unrefreshing, moderately severe, present at least 50% of the time. His cognitive impairment he ranks as severe, present 50 to 75% of the time. And he has orthostatic intolerance he ranks as very severe, 75 to 100% of the time. So he meets the criteria, the National Academy of Medicine criteria for ME/CFS due to impaired function associated with fatigue, post-exertional malaise, unrefreshing sleep, cognitive impairment, and orthostatic intolerance, all longer than 6 months in duration. He also has other symptoms associated with his long COVID: shortness of breath, myalgia, nausea, loss of taste and smell, skin rashes, and very infrequent mild tinnitus, vision problems, and allergies. So this is the Nacul test. It looks like it got moved here, sorry. The circle was supposed to be around the heart rate, and I think it got jostled in. But anyway, you can see his heart rate in the supine position is 65 and 67. We did it 2 times. So 67 beats per minute. Sorry, I didn't look these over after they got reformulated. And then at the bottom, his heart rate at 8 minutes had reached 138 beats per minute. So the test was terminated at 8 minutes. You can see in the comment section, he's getting increasing symptoms of orthostatic intolerance and tissue, the sympathetic drive causing peripheral vasoconstriction and lightheadedness and shortness of breath. His heart rate went from 65 to 138. That's 73 beats per minute increase simply from standing in place. So you can see this is a dramatic example of postural orthostatic tachycardia syndrome, which only requires the heart rate to be 30 beats per minute. This is just one more. This is an ME/CFS patient who went diagnosed for a decade. When we did her lean test, this is at least 2 years after she became my patient. You can see that her supine blood pressure went from 116/60 to 93/80 at 10 minutes. She lasted the entire time. She also had her pulse went from 85 to 120. And the interesting thing is you can see her pulse pressure, which is the difference in the systolic and diastolic blood pressure, went from 56 to 13. And 13 is an incredibly low pulse pressure. It's barely, her cardiac output was dramatically reduced. So the second thing I wanted to talk about is mast cell activation syndrome. And mast cell activation syndrome is not the genetic mastocytosis disease, but it's an illness characterized by irritable mast cells or very sensitive mast cells, which are distributed throughout the body. And when the mast cells release their histamine and products, it can create symptoms throughout the entire body. And the cause is not really known, but we know it's associated with chronic inflammatory conditions. So it may have something to do with chronic immune activation causing this widespread annoyance by mast cells. This is one set of criteria. There's not a complete consensus in the field of allergy immunology about how to diagnose mast cell, but this comes from the reference down below, which is Lawrence Afrin, who's a longstanding
1 minute,
mast
Dr.
cell,
Bateman.
thank you, mast cell expert. And he says if you have episodic symptoms affecting 2 or more organ systems, improvement on H1, H2 blockade, anti-leukotriene medications or mast cell stabilizers, and then some lab evidence. And generally we look for serum tryptase, but you can also do serum urine tryptase and 24-hour urine histamine metabolites. So these would be the systems involved: skin, GI, cardiovascular, respiratory, nasoocular, and you can also have neurologic symptoms related to mast cell activation. So if 2 or more systems are involved, and you can actually do an empiric trial with H1, H2 blockers, and or add Montelukast to it. And sometimes cromoline's a little more difficult, and as for a diagnostic test. And then looking at total serum tryptase and 24-hour urine levels of these histamine metabolites can be the way. It sometimes requires several episodes of testing. You need to test when the patients aren't on the medications, and you may have a higher chance of picking up the elevated tryptase and these elevated metabolites if the patients are symptomatic. So this is just a reminder of our time-tested treatment approach. And I hope that this has given you just a very quick overview about how it's possible to manage patients with multi-system illness. Just dig in, have your individualized treatment, and see if you can provide as much supportive care as possible. Thank you very much.
Thank you, Dr. Bateman. Now I'd like to introduce Dr. Louise Nacul to speak on the Canadian context before we move on to our panel discussion on current research. Dr. Louise Nacul is a physician, researcher, and professor. Currently, he is the medical and research director of the Complex Chronic Diseases Program in Vancouver and a clinical associate professor at UBC. He is a principal investigator for the ICanCME network and holds grants from the CIHR and the NIH. Dr. Nacul has taught and conducted research in epidemiology and public health in the UK. As a clinical associate professor in epidemiology UK, he directs the ICanCME group, a dedicated research group that leverages professional lay partnerships to better understand the biomedical basis of ME/CFS and its personal and societal impacts. Dr. Nacul continues to conduct research with ICanCME, strengthening collaborations between ICanCME and research teams in North America. Dr. Nacul will speak for a couple of minutes, and then we will have the panel with Dr. Muirhead and Dr. Bateman. Over to you, Dr. Nacul.
Thank you, Dr. Clark. I hope you can hear me well. I will give a very brief presentation on the perspectives from Canada and what's happening in this part of the world. And I'll base this presentation on the health needs assessment framework, which includes the epidemiology, existing services, and the effectiveness of interventions. It has been suggested that about 600,000 people have ME or CFS in Canada. However, if we think about pure ME and based on international estimates, it is likely that we are talking about 150,000 people with pure ME in Canada. That's still a lot of people, and Canada, of course, is a large country. And there are 3 provincial services providing services for people with ME, CFS, which include the Complex Chronic Diseases Program in British Columbia, the Environmental Health Clinic in Ontario, and the Integrated Chronic Care Service in Nova Scotia. So in combination, these services can only attend to a small proportion of people with ME in Canada. This means that the primary care physicians and the non-specialists will be not only the first point of call for people with ME, but often the only resource that people with ME will have access to. Evidence is quite limited. However, I would suggest in terms of recommendations from experts two documents. One is the American document on essentials of diagnosis and management. It's just recently been published by the Proceedings of the Mayo Clinic, and also the European expert consensus on diagnosis and care of people with ME. The ICanCME network in Canada has been working towards developing a Canadian guidelines for the disease, and we hope that sometime next year they will be available. So how can the non-specialists help? As a non-specialist, you can help by being a good doctor in spite of uncertainty. Believe, validate, and support your patient. Give an early diagnosis and safe management protocol to their patients. Recommend pacing and energy management, as just mentioned by both my colleagues in previous presentations, and avoid harmful or unhelpful advice, such as it's all in your head, or get on and exercise and everything will be fine. And I quote here from a paper by Bateman and others: even after diagnosis, patients struggle to obtain appropriate care and have often been prescribed treatments such as graded exercise therapy that could worsen their condition. I'll just finalize by very briefly mention one thing in this slide, which is that as any other chronic disease, ME goes in phases. So there is an evolution from the early to later stages of disease, and the reversibility is much more likely in early disease. And this is a very good justification for early diagnosis and early intervention of people with ME. Those with established disease, the prognosis is much worse, and we are talking about possibly a recovery rate of about 5% only. So early intervention by a good doctor, that's the main recipe for people with ME from the non-specialist and from the specialist services as well. Thank you very much.
Thank you, Dr. Nacul. And now we will have a panel discussion with Dr. Muirhead, Dr. Bateman, and Dr. Nacul. Approximately 5 minutes per person. Who would like to go first for the panel? Dr. Muirhead, would you like to start? And then Dr. Bateman, and back to Dr. Nacul.
So just taking on from the last point that you made about early diagnosis does seem to, and good care does seem to improve the outcome. Is it not possible that there are some milder subtypes which just are shorter and therefore those patients would get better, and those who have a late diagnosis have been ill longer and by fact have a more severe subtype? Just a discussion question there.
I'd like to comment on the fact that we base our criteria on people. We have designed the diagnostic criteria based on people who've been sick a long time. And we've really lost the window of opportunity to study the early stages of ME because people get a diagnosis so late. I am just so excited about the opportunity during this horrible pandemic, the COVID-19 pandemic. We're going to have just the opposite. We're going to have large numbers of people that we track from the onset of their illness and can study, what happens to lead. And it will help us understand how many people get better. I think the statistics that show that's only a 5% recovery rate are based on people who've been sick for a long time, usually more than 5 years and sometimes even longer. So I'm hopeful that we will be able to make earlier diagnosis, get diagnostic clues about how the illness evolves, and really change the number of people that go on to have very long-standing and severe chronic illness. I'm hopeful for that.
I can only totally agree with with your points. if you look at the post-COVID clinics, for example, here in British Columbia, there are 4 post-COVID clinics in the province. The proportion of people who have fatigue and related symptoms at 3 months is very high. We're talking probably about 50% or something like that. And then at 6 months, the numbers drop. And then they continue to drop, but we know little about that. And one of the things that people at the post-COVID clinics are doing here is to recommend pacing and energy management early on. We don't have any evidence as such how much this message is the right one, but we believe it is. We strongly believe it is. We don't have evidence to prove that. But I think we just need to look more at the natural history of early ME/CFS or post-viral syndrome, and this will give many important answers to people with ME in general.
I have a personal view based a little bit on based on my clinical experience, that with orthostatic intolerance syndromes are probably very common in the beginning of the disease. We just don't look. I mean, I think it's the reason that people become so disabled so quickly. And this data show that the sicker people are and the longer they've been sick, the less obvious their orthostatic intolerance is. It becomes well compensated. So, but there are studies in even severely ill people that brain perfusion goes down in the upright position. Even very ill people just sitting up in bed can have changes in blood flow in the brain with ME. So I do think that the longer people go without support and without guidance about the things that make illness worse, the more likely they are to become severely impaired. And so early diagnosis can be critical, and understanding the components of disease, whether it be the inflammatory components, the circulatory components, or these metabolic components, because I also firmly believe that people get worse and worse if they're constantly pushing into post-exertional malaise. That preventing post-exertional malaise probably stabilizes illness and gives people the best chance to recover.
Mm-hmm.
I did see one long COVID patient who got sick in April of 2020, mostly recovered, just had fatigue over the summer, and went and started an exercise program in September, and then blossomed into full-blown ME/CFS symptoms. We were able to, after 3 30-minute bouts of exercise, Monday, Wednesday, Friday, after the third one, she just became severely ill. All the typical symptoms of ME. We were able to intervene very early, and with the right supportive care. She was sick about 6 weeks before she got a diagnosis, and then within another 6 weeks, she was back to her state over the summer of mild post-viral syndrome. So there is at least that one anecdote of someone who dramatically worsened their long COVID by aggressive attempts to exercise.
Sabrina's asked a great question. What's the most current and exciting research in ME?
What do you think?
So in the UK, we have Decode ME, which is looking at the genome-wide associations of 20,000 patients. So it's the biggest study so far of ME/CFS, and we are recruiting and looking into the genome-wide associations. It will give us clues as to which avenues to pursue in terms of researching the disease mechanisms which may underlie the pathophysiology. So I think for me that's very exciting because it's happening here in the UK, and we'd love to see more similar studies around the world collecting similar data.
If I can mention, we just got a grant here in Canada from CAHR to do a double-blind randomized clinical trial on low-dose naltrexone for people with post-COVID fatigue syndrome. So I think that's very exciting. we're going to look at many outcomes, and of course, autonomic dysfunction will be one of them. But we want to recruit people at 3 months of illness or post-COVID fatigue rather than later on. So I think it's an opportunity to look at early intervention in this population. And it's important to say, when you talk about post-COVID fatigue syndrome, it's just a subgroup of long COVID. There are other people who have long COVID that are ill for a number of other reasons. And of course, organ damage is one of them. People end up with lung fibrosis, end up with other lung abnormalities, cardiovascular and thrombotic abnormalities, kidney failure, neurological, and so on. And it's important that, I mean, in this study, we're aiming to capture those who have a clinical picture which is indistinguishable from ME/CFS, but earlier on than the 6-month time point. So we're still in preparatory phase. We just learned about this, but we're very excited about trying some specific treatments for this population, which will have implications for other people with ME/CFS, I'm sure.
Excuse me. Now I'd like to introduce Hilary Robertson to join the panel to say a few words from the patient perspective. Hilary, are you there?
I am. Thank you very much. I have some words prepared. I am a person living with ME, so I need to have my cheat sheets. I'm the co-chair of the ME/FM Society of BC, and I thank the Federation and ICanCME Medical Education Working Group for partnering with us on this education. So prior to ME, I was an active, robust woman. I had my PhD, my own consulting practice, held executive positions in long-term care, acute care, and community care. I was faculty at university and taught graduate studies in 2 programs and supervised thesis students. I had acreage, animals. I was active and an accomplished textile artist. Sorry, I have irritable larynx syndrome too. My journey to diagnosis is like many. In Canada, my onset with ME was slow, but with steady decline. I contracted an unknown virus and was hospitalized for 4 days with fevers reaching 106, blisters across both meridians and whole body involvement. My doctor advised that 19 others had contracted the same virus. 2 others were hospitalized, yet they were unable to determine which virus it was. 1 year later, I told my physician I felt the virus was still in me. Every time I overexerted, I became ill with flu-like symptoms and was in bed for 4 days. I began to use allied services to deal with muscle aches, acupuncture, massage, chiropractors. I invested in a myriad of supplements and special diets. I exercised and lived with what I felt was an extremely healthy lifestyle, and was definitely one of those that pushed through and presented as a highly motivated and achieving individual. Each year, I lost capacity, although my symptoms were, as with many ME, changeable. One GP visit, I was concerned with unrefreshing sleep. Another, it was intolerable body aches. Another was increasing GI symptoms to the degree that I couldn't leave the house. I ached, I was ill, I was failing, yet all my tests were negative. It was clear to my physician that I was ill. I lost 60 pounds in 6 months. I had CT scans, ultrasounds, MRIs, x-rays, blood work. One draw was 28 vials. I was sent to GI specialists, neurologists, and surgeons. I had colonoscopies and endoscopies. I was flown to Calgary from British Columbia to see a GI specialist. I was diagnosed with severe IBS. I could hardly walk or speak. I was sent to ENT and speech therapists. It was suspected I had ALS, a brain tumor, or MS. Finally, with brain scans, a neurologist told me that I was a healthy 70-year-old and to hire a personal trainer. I had just turned 63. I did as he suggested and went into full collapse. 6 months later, I was admitted to the CCDP after a 33-month wait list and formally diagnosed with ME and other comorbidities. My report stated that due to severity and length to diagnosis, my prognosis for recovery was poor and that I was permanently disabled. I was now housebound using bed rails, wheelchairs, and walkers. 13 years from onset of the virus. Thousands of healthcare dollars were spent and thousands of dollars in allied health services. A career interrupted, income lost, a life completely interrupted and forever altered. I am fortunate to be one of the ME patients who has gained some capacity through supportive care. Pacing, of course, has been critical. I will be in bed today because this will take most of my energy. My story, as you know, is not unique. I encountered stigma, dismissal, and denial throughout my journey. I had caring physicians who wanted to do their best, but had no knowledge of ME. We learned together, and I can say absolutely that my GP has now gone on to diagnose others in a shortened time frame, leading to a potentially better trajectory for their future health. I live in hope that through education such as this amazing opportunity today, that we will lead to a better diagnostic journey for others and ultimately increase research for biomarkers and treatment. Thank you.
Thank you so much, Hilary. Do any of the other panelists have any other points to add before we move on to Q&A? We've got a minute or two for anyone to cover anything they feel they've missed. Okay, well, we'll move on to Q&A, and I will start with the questions on the chat box, and then we also have some questions that were emailed in before the session. Some people were very eager. So one of the questions in the chat box says, oh, what is the current in research? That was already asked and answered. The next one says, it really seems challenging to make an early diagnosis for someone not specialized in this area. What are your key pearls on not missing this diagnosis for primary care docs and nurse practitioners? So to the people on the panel, anyone want to take up that question? Key pearls on diagnosis for primary care docs.
I'll just say that the key pearls are number 1 and number 2 of the IOM criteria, which is impaired function and post-exertional malaise. This is the functional impairment, as I tried to, it's as physicians, we don't really learn how to assess people's ability to function. We ask about symptoms, but we don't ask about function. And we don't ask about what happens when people do things. What are the consequences? So those two things are the leading question. That's why they're the leading questions in the IOM criteria. And then there's those other major symptom groups, but every clinical diagnostic criteria for ME/CFS include impaired function and post-exertional malaise as the clues, the leading clues.
Thank you. Next question is directed to Nina and Hilary. Can you explain a bit more about what PEM feels like?
You go first, Hilary. Hilary first.
Yeah.
Complete and utter body exhaustion. I actually lose the ability to speak. My tongue, I get very spastic. I get muscle twitching very rapidly. Nauseousness overwhelms me. Heat, I flush. And I feel like I've got lactic acid throughout my whole body for days on end.
Mm-hmm. And Nina, would you like to add to that? Yeah.
It's very similar. That sort of whole body exhaustion, like you're running a marathon, you've hit the wall and you cannot even think straight. You have all these multi-system symptoms. Like you, Hilary, I also get sort of my tongue, swallowing even, breathing can be hard, turning in bed. Hypersensitivity increases to all the sort of sensory overload, sound, light, smells. Movement is painful, concentrating is difficult, and you just feel flu-like and just need to go to bed in a darkened room. A little bit like migraine sufferers describe as well. Just can't function.
And moving on to, I've got questions that were emailed in, so they're not directed to anyone in particular. Can you clarify the difference between fibromyalgia and ME? Which of our panelists would like to take that one on?
Dr. Nacul, why don't you go first? Did you raise your hand?
No, I was just going to, I mean, I have raised your hand just to if I may, to give another comment about post-exertional malaise. Just to mention, I was going to ask you, but very briefly, ask Lucinda and Nina as well. I observe in my patients that when they are improving, post-exertional malaise, duration of post-exertional and severity of PEM are good indicators that people are doing well. So that's one of the questions that I like to ask them in terms of, because everything tends to improve at the same time, but PEM is, I mean, this is anecdotal, but I find quite a good indicator of if people are doing well. And of course, if you're not doing well, the symptoms will be more severe. But in relation to fibromyalgia and ME/CFS, I'll just say one or two words and then I'll hand over to you. There are lots of overlap, but I think they are distinct diseases. Fibromyalgia, the main, it's about generalized pain as the main symptom. It's about the pain pathways and the hypersensitivity to the pain stimuli and the response from the individual with fibromyalgia. And this is accompanied by a number of other symptoms that overlap with symptoms of ME/CFS, fatigue being one of them. But all the pathophysiology of ME is different. Pathophysiology of ME is more like a neuroinflammatory disease, and which goes through a number of other manifestations or other abnormalities that flow from the original abnormalities that I believe are pro-inflammatory state and the communication between the immune and nervous system at the beginning, and then there is a cascade of events that go after that. So I think they are different entities, but clinically they may be similar to each other, and this is common in medicine. That's why we have differential diagnosis often, and also very importantly, appreciation that comorbidity is very, very common. Maybe 60% of people with ME will have fibromyalgia. That's one of the statistics that I come across.
Maybe I'll add my 2 bits to that. I think sometimes we mistake clinical criteria for a phenotype of a disease. So if the criteria for fibromyalgia describe the phenomenon of pain amplification, and I see fibromyalgia, I like to use what are called the 1990 American College of Rheumatology criteria, which diagnose fibromyalgia as chronic widespread pain and tenderness. So it has to be more than 3 months in duration. It has to be widespread in 4 quadrants of the body, and there has to be tenderness. And they left those criteria behind and created additional criteria that have more and more overlap with all kinds of other illnesses. So I see fibromyalgia as more as a phenomenon of widespread pain amplification centrally, and it can be comorbid with many, many illnesses. It's highly comorbid with rheumatologic illnesses, for example, very commonly present, but it's not inflammatory. It's more of a neurologic pain amplification. It's inflammatory, probably neuroinflammatory, but not the typical kind of inflammation that we think of in rheumatologic diseases. And it commonly occurs in people with ME/CFS, but not always. Which is why pain was left out of the criteria. And I think my theory is that people develop pain, ME/CFS people develop pain because of the additional physiologic stressors, that they have sleep deprivation and their life falls apart, and they have endocrine abnormalities and things, and eventually develop widespread pain. But again, that's just my clinical impression. So they're really not mutually exclusive diagnoses, they're descriptive diagnoses at this point. And in terms of the phenotype, fibromyalgia is a lot more common. and people are generally more functional. All the symptoms are more responsive to medications. I think of them as sensory symptoms. So pain responds to pain meds and sleep responds to sleep meds. And they just really, it's much easier to control. And people with fibromyalgia, there's a large literature. People who only have fibromyalgia respond to exercise, both weight training and low impact exercise. So it's especially bad when you have ME because the ME predominates and then you get the pain on top of it, but you're unable to take meds and you're unable to exercise. So it becomes, those people are by far, the more syndrome criteria you meet with ME, the more sick and impaired you become. So if you have pain amplification, if you have multiple chemical sensitivities, the function goes down and the symptom burden goes up.
Mhm. Okay, well, moving on to the next question. What can be done to better support ME patients? That's a big one. All right, who would like to take that on? Because this came in by email, so not directed to anyone in particular.
I'll say a fast answer: education, education, education of clinicians. We all need to know this illness. We all need to take care of people. That's why we're here today.
Mm-hmm.
And the other thing is early recognition. I mean, take this the patient seriously. Encourage patients to come to your service early on, because very often patients are inhibited to come to the health services because they may anticipate a less than a positive reaction from the health professional. So just recognize and support early on.
I'll put my answer in as well. I completely echo the education, 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 and recognition and support. But the other thing that I would add is helping that patient understand how small their energy envelope is to begin with, and not going beyond it. And it does go back to a comment that Lewis made earlier about does PEM get less severe as you get a little bit better? And I think that patients are equally getting better at avoiding causing it at a similar rate as they're getting better. So by not triggering it, it might be enabling them to recover slowly physiologically. So the symptom is reflecting the improvement in their self-management, as well as the improvement in the underlying condition. So it's chicken and egg, really.
Okay, moving on to the next question. Just reflecting on stigma and how this impacts the people seeking care with this illness. Any reflections? Any comments on stigma and what patients with ME are going through?
I think Hilary probably will be the right person to talk about that.
Yeah.
So the Society and the Complex Chronic Disease Program recently completed a pilot study of patients throughout British Columbia and the clinicians. It was a preliminary grant funded by the Vancouver Foundation. And there was 4 distinct themes on our website. The long report and short report are contained there under our research, but dismissal and stigma was a major theme coming out of that research. And one of the most concerning aspects of the outcome of that is that patients self-edit access to care. So they will hold off seeking care when others with other diseases would attend emergency, attend their physicians. And so that was a highly concerning issue for them. There's lots more, so go to the report on the MEFM research website.
Thank you, Hilary. Well, perhaps we have time for just one more quick question to the panel. This came in a spreadsheet, so the box limited what I could see in the question. But the first section of the question said, what do you recommend to reduce the mitochondria load? And there may be a little bit more to that question, but I think the gist of it is from the panel of experts, are there any recommendations that you can suggest for helping the mitochondria?
Pacing, I'll just start by saying pacing is one thing
Uh-huh.
to protect the mitochondria. But I don't think there is any evidence-based treatment for the mitochondrial dysfunction, but I'll hand over to
There
others.
is some evidence in the literature around pharmacy and the use of many medications and the fact that they can slightly block or inhibit mitochondria. Particularly some of the antidepressant medications can change your mitochondria. So they may help people coping with the depression of adjusting to a chronic disease, but yet further exacerbate their lack of ability to access and deliver energy at a cellular level, which could be a very interesting perspective to look at. So with any medication, the rule of thumb is try one at a time, start low, go slow. And if it's not working for the patient, then maybe it's not right for them, and to listen to them and document that. But also bear in mind that it might take the first 2 or 3 weeks to recover from actually seeing you and getting the medication in the first place. So to be patient with finding out if it's working or not.
Thank you. Well, that is the time we have for questions. Thank you all very much to our speakers, panel members, for enlightening us on the complex issues around ME. And thank you all for attending and participating through your questions. We're now at the end of our webinar, and I would like to invite Dr. Petruccelli to make closing remarks. Over to you, Carissa.
Thank you, Teresa. Thank you for all the participation today and to just an outstanding panel of speakers. Thank you, Hilary. Thank you, Dr. Bateman and Dr. Nacul, Dr. Muirhead. I think this is just such a fantastic and timely topic. We know that it impacts women predominantly, and we know that it really is an underdiagnosed condition. There's so much education and opportunity for research, and a very important topic. I really want to take the opportunity to thank Hilary, Robertson, as well as Sue Kazay for bringing this to our attention. And thank you for everyone's participation. And we look forward to the ongoing research and educational opportunities. So thank you very much to everyone for participating today.